in Research Ireland event today. We are recording, so just to let you know that we are recording, so please keep your cameras off during the recording. So our event today is titled Reproductive Rights, Gender and Employment in Ireland. Where are we now and where to from here? So my name is Aileen Butler. I'm a committee member of Women in Research Ireland, and I'm joined by my fellow committee members, Valeska Lima, Kathy, Mairead O'Connor, and Arjamond and Anna Truzzi. So our event today intends to promote a conversation about the relationship between reproductive rights and gender, especially in relation to employment in Ireland. So the ability to regulate fertility and decide when, if and how to have children has in no small part facilitated women to participate in the workforce. This is an important time to have these conversations, especially as we are witnessing the rollback of reproductive rights in countries like the US. Here in Ireland, there is an ongoing review of the abortion legislation that was implemented following the majority vote to repeal the 8th Amendment from the Constitution in 2018. By contrast, assisted human reproduction has never been formally regulated in Ireland, and a bill to do so is currently before the Dáil. So it is in this context that we meet today to discuss progress on these important issues to date and consider where to from here. To understand more about these issues, we are delighted to be joined today by Dr. Catherine Conlon from Trinity College Dublin, who is an expert in the social politics of reproduction. We would also like to welcome Dr. Olivia McDermott from the University of Galway, who is an expert in medtech regulatory affairs and manufacturing and healthcare operational excellence. So we'll be taking questions from the audience at the end of the discussion. So type your questions into the chat box during the event. And as I said before, for the recording purposes, please keep your video off and your audio muted. So with that, I will hand over to Dr. Catherine Conlon. Catherine is an assistant professor at the School of Social Work and Social Policy, Trinity College Dublin. Catherine has a strong track record of applied policy research, and she was PI most recently for the HSE's Sexual Health and Crisis Pregnancy Agency Commissioned Unplanned Pregnancy and Abortion Care Study, which has been designated by the Department of Health as the service user data strand informing the ongoing legislative review of the 2018 Act. Her new research is an award under the HEA Shared Island Programme and looks at the concept of reproductive citizenship as it presents comparatively across the 2 jurisdictions on the island. Catherine will have 10 to 15 minutes to address the audience, so over to you, Catherine.
Thank you, Aileen. So I'm just going to share my slides here, if you can tell me when you're seeing those.
Yep, they're appearing there now if you want.
Okay.
Full screen.
Yeah, in presentation mode. That's great. Thank you. So thanks to Women in Research Ireland for inviting me today. I'm talking about findings from our research, the study called Unplanned Pregnancy and Abortion Care Study that was commissioned by the Sexual Health and Crisis Pregnancy Programme, as Aileen said. And this research was carried out by a team of us, including myself, Dr. Kate Antosik-Parsons, who is here today as well, Aileen Butler, who you've just met, as well as Joe Green and Manu Lee at the School of Social Work and Social Policy at Trinity College. So just taking, having regard to the overall theme for the session, just remembering the relationship between reproductive rights and gender equality as a matter of international human rights law since 1994, the Conference of Population and Development and the 1995 Beijing Platform for Action under the UN acknowledged reproductive rights as including the right of all to decide freely and responsibly the number, spacing and timing of children, and to have the information and means to do so free from discrimination, violence or concern. And it's been acknowledged that ensuring access to safe, respectful and non-discriminatory abortion care is recognised as fundamental to meeting the SDG goals, particularly 3 relating to good health and well-being and 5 relating to gender equality. So that's the broader context in which we are considering abortion regulation in Ireland. And just a very, very potted history as regards abortion regulation in Ireland. We had in 1983 a constitutional amendment inserted into the Irish Constitution that accorded equal right to life to the fetus from the moment of conception with the mother or woman. And the effect of that was to prohibit abortion. But even in 1983 and since then, there were continued numbers of people from Ireland who travelled overseas to access abortion care. as well as once online telemedicine abortion services became more available and medical abortion became more safe and effective, an increase in incidence of importation of abortion medication was noted. There were also decisions by UN committees that Irish law violated international human rights law and constituted cruel and degrading treatment. And we also had, since the implementation of the 8th Amendment, tragic cases before the courts of women that were seeking abortion and being brought before the courts under the 8th Amendment, as well as women in health settings who were denied treatment with fatal outcomes. And all of this put consideration of the 8th Amendment onto the political agenda and eventually into the programme for government in 2016, who then referred the 8th Amendment to a citizens' assembly process. And that process recommended a referendum, which in 2018 repealed the 8th Amendment by a majority of 66%. And that brought us to where we are now, which is that abortion was legalised in Ireland during 2018, coming into effect on the 1st of January 2019. And that act regulated abortion under 4 different sections. Section 9 relates to access to the right to have an abortion where there's a risk to life or the serious harm to the health of the pregnant woman, including in an emergency situation, or where the pregnancy is likely to lead to the death of the fetus either before or within 28 days of birth because of a fatal fetal anomaly. So those 3 sections have no limitations as regards gestation. And then the final section allows for abortion without restriction up to 12 weeks gestation, section 12 of the Act. So just a couple of things under the Act as well, a provision for review of the legislation after 3 years focused on the operation of the Act was provided for, and that is due to report by the end of this year. The Act also allows for conscientious objection for anybody working in healthcare to opt out of being involved in providing abortion care. And the Act also provided that those seeking access to abortion under Section 12 would have to have a mandatory 3-day wait between their first consultation and administration of care. So the study I'm talking about is the Unplanned Pregnancy and Abortion Care Study, and it was commissioned by a component of the HSE, the Sexual Health and Crisis Pregnancy Programme. And their concern was to understand a description of the experiences of women who availed of unplanned pregnancy and abortion care services since the implementation of the Act, and to understand their experiences and in particular look at their trajectories or pathways through the care service. It was after it was underway for some time, the Department of Health designated the service user strand of the legislative review that is underway, and it will sit alongside a service provider strand as well as a public consultation strand, and all of those will be considered by the independent chair, Barrister Marie O'Shea, who is undertaking the review. In our focus of the study, we did look at women seeking abortion under all sections of the Act, but for the purposes of time today, I'm just going to discuss our findings under Section 12 of the Act, but the full research report has been published. So just to describe to you the model of care that is implemented to provide abortions under 12 weeks gestation, which are without restriction. So a person seeking care under that section of the Act, the first point of contact for them is to a GP or a women's health clinic who has opted in to be an abortion provider under the Act and entered into a contract with the HSE to provide abortion care. To find a provider, the HSE has made available a helpline, and that helpline called My Options provides names of provider. It provides information on all services relating to unplanned pregnancy and information on the abortion service, and also refers people to counselling services. For anybody seeking care up to 10 weeks gestation and who have no clinical indication, their care will be fully provided in a primary care setting by their general practitioner or a women's health clinic via early medication abortion. If a person presents who have got clinical indications at any stage under 12 weeks, or if they're between 10 or 12 weeks gestation, they'll be referred to hospital where their abortion care will be administered there, usually under a daycare model where medical abortion will be administered under the observation usually of a midwife, or in very limited circumstances, surgical abortion may be provided. There is also, to support people self-caring for themselves during the administration of medical abortion, a 24-hour nursing helpline is available through the My Options helpline as well. Abortion care is a funded service free at the point of care for people accessing abortion in Ireland. So for our study, we undertook the research between October 2019 and December 2021. We altogether did qualitative interviews with 58 people. 12 of those had sought or accessed care under Section 11 of the Act relating to fatal fetal anomaly. And the element of the study I'm speaking about today relates to 46 qualitative interviews with people seeking care under Section 12 of the Act under 12 weeks gestation. All of these people were recruited at the time of presenting for care. So when they contacted their GP or women's health clinic or hospital for care, they were recruited into the study for a qualitative interview under 12 weeks, for having access care under 12 weeks gestation. We conducted the interviews face-to-face pre-COVID, and then once COVID was implemented and restrictions were implemented after April 2020, we conducted all interviews remotely. And we did note that the quality of data collected either face-to-face or remotely by Zoom in most cases, or telephone, the quality did not seem to be affected by the format of interview. So as regards our findings, what did we hear people in the study say about their experiences of accessing abortion care in Ireland under 12 weeks gestation? First, as regards what people said about their position when seeking care. We heard people talk about how they were clear on their decision when they sought care under the Act. They did not have a strong interest in counselling or support with making their decision. There were, and it was a consequence, we felt, of the legacy of the regulation of abortion and the non-provision of abortion in Ireland up to 2019. They were anxious about security of access and care, and out of that anxiety wanted to contact a provider quickly and wanted care provided promptly with no delays. And one of the, in our analysis, we noted that that position that people portrayed when seeking care was inconsistent with the component of the Act that requires a mandatory 3-day wait between first consultation, presenting for care, and having the care administered. As regards how people accessed care, we noted, even though the model of care intends that people will make first contact with the My Options helpline, hear there of a provider that's in their locality, and then contact their provider, we noted in the study 13 distinct pathways to care. Only 1/3 of people we spoke to had self-referred to My Options as their first port of call. But many in the study had never encountered My Options at any point during their care pathway. 11 people had self-referred to a provider that they had identified themselves as a provider of abortion. And therefore, there were a number of people who sought to access care without the My Options helpline. And in that process, there was evidence of them encountering delays up to the point of obstruction. And how we portrayed the experience of trying to access care without having found My Options helpline, we're running the gauntlet. We noted that there was not a tendency of people in GP clinics or women's healthcare clinics or hospitals to refer women either to My Options or to a provider. And medical ethics broadly would say that if you are a healthcare provider and a person presents to you seeking healthcare and you do not provide that element of healthcare, there is a medical duty on you to refer that person on to somebody who does provide, or to a mechanism through which they can access that healthcare. And it does not seem to us that that ethical duty is being observed in the context of abortion care. Well, the My Options helpline, for those who did access it, was positively assessed. There was a general consensus in the data that there not being available an open list of providers is impeded access and causing people to experience these delays and obstructions along the way. We also noted that sparse and uneven coverage of providers, because currently of 2,500 GPs in Ireland, only about 450 are registered with the HSE to provide abortion. That sparse and uneven coverage is raising logistical access issues for people, and also has symbolic impacts. People are asking, what is it about this particular element of healthcare that means that it is not as available as all other forms of primary care or sexual and reproductive health care that is making it an area of healthcare that isn't seen as acceptable or as available. But once people had found GPs, how did they evaluate them? So we heard in the study that GPs that women attended for abortion care were portrayed as highly committed providers who often went over and above their usual practices in providing healthcare. While this was very well evaluated by women, it does raise for us questions of sustainability of the service. And one of the things about the Irish model of care, which does incorporate abortion care into primary health care generally, is that it has a lot of potential for normalisation. But this confinement of abortion care just to highly committed providers is, and that those providers then going above and beyond their usual practices in order to provide abortion care, does run counter to normalisation and raise those concerns for us. Women's health clinics were commended as specialist sexual and reproductive healthcare providers, but yet there is very limited coverage in that they're only available in Dublin. When women talked about their experience of care, attending doctors in women's health clinics or GPs in order to have medical abortion administered, we heard them talk about very detailed recall of the guidance that was given to them for self-administering the abortion care at home, including managing pain or bleeding. And there was an indication by people in the study of very careful adherence to that guidance. In terms of the model that does anticipate people will self-care for their abortion using medication, most people in the study valued the comfort and familiarity at home as a space that allowed for their own privacy and personal observation of any rituals that they had around the abortion that they wanted to attend to. But yet women in the study noted that they do need, that this model of care does mean that everybody who's seeking abortion has a private, comfortable, appropriate space in order to self-manage their care. And this is not the case for everybody. So people in the study commented, if you were homeless, if you're co-residing with people you did not want to know that you're undergoing an abortion, or if you're in an unsafe domestic environment, such as subject to domestic violence, then you may not be able to self-administer your abortion at home. And this raises the need for a daycare option as part of the model of care. We noted that while the model of care does allow for a follow-up appointment, there was a tendency for people not to attend their GP for the third follow-up appointment unless they had some complications or symptoms. One of the things we noted in the data when people talked about their evaluation of providers was that on the one hand, if somebody had access difficulties because of there not being a provider local to them, they were certainly concerned with having a greater level of coverage to have more widespread provision. But at the same time, women did value the extent to which the providers they attended were experienced and were very committed. And there was a concern that if there was a mandate on GPs or doctors to provide without being willing providers, that would affect the quality of care. And so a balance needs to be struck between achieving wider provision or having experienced providers. In terms of...
Just to let you know, there's about 30 seconds or so left.
Okay. Yeah, thank you very much. In terms of attending hospital care, people attended hospital care between 10 and 12 weeks gestation, or if they had clinical indications. The care providers in hospital were equally found to be highly professional, non-judgmental, but there was a concern by people in the study that this location of services within maternity settings were often disconcerting, described as being in the nether region of hospitals. And the other thing people noted was the choice of surgical method of abortion was not really available in the Irish context. Just to note, because the focus of the session today was on reproductive rights, gender and employment, a couple of things we noted just across the data set in terms of comments people made about abortion care and its relationship with their work settings and employment. People noted that scheduling 2 appointments entailed coordinating with their work schedule. It was facilitated by highly responsive GPs who sought to give early morning appointments or even lunchtime appointments, or by the remote consultations, but it did often entail a delay, particularly because of the 2 appointments. That was exacerbated where there was no local provider or where travel was required. Self-managing the abortion usually entails about 12 hours of self-care with an indeterminate level of symptoms, and this needed to be coordinated and managed, particularly by women where they had to also attend at work. GPs did offer medical certificates for women if they were working, but some were reluctant to seek those for privacy reasons. Women noted that there were symptoms of hormonal changes in post-abortion days that had potential impacts for their capacity to work that they had often unanticipated. And where concerns rose for incomplete abortion or where the medical abortion did not seem to be complete in the first round, the management of that was protracted, attendance for multiple blood tests or attendance at hospital for repeat medical under observation. And that indeterminate time frame was hard to manage with employment demands as well. So finally, just to end with the overarching view of what people said about the Irish model of care: innovative for being community-based, for a potential to promote normalisation because it was wrapped in with your broader primary care services, but a high burden on the person seeking care to navigate complex fragmented care pathway, and the ethical duty on doctors to refer a person seeking care to a provider's not being observed. The remote model of care is enhancing accessibility. Timeliness in accessing care is a key concern for women, and this does seem to be at odds with the mandatory 3-day wait. Limited availability of surgical abortion in the Irish context means no choice of method. And while there is a strong evidence of highly conscientious commitment by providers, there is still limited geographical spread of providers in Ireland. So I leave it at that, Aileen, just to say, acknowledge our gratitude to the women who took part in the study. Thanks, and apologies for going over time.
Not at all. Thanks very much, Catherine. That's a tough gig to condense that study into such a short presentation, as I know, because I was a co-author on it as well. So I'm going to hand over to our next speaker, who is Dr. Olivia McDermott. And Olivia is an assistant professor in medtech regulatory affairs at the University of Galway. She's the director of 4 postgraduate programs in medtech regulatory affairs run by the University of Galway in conjunction with ATU Sligo. She's published over 50 peer-reviewed journal and conference papers, including a recent comparative review of legislation on assisted human reproduction in Ireland and other countries. So Olivia will have 10 to 15 minutes to address the audience, and just a reminder that if you have any questions, to pop them into the chat, and our panel will ask them. So over to you, Olivia.
Thank you, Aileen, and thank you to the group for having me here today. It's an honour to be asked to attend. So just to put in context, Aileen, you had asked me to speak on this study in relation to a comparison of assisted human reproduction regulation in Ireland with other developed countries. And I've also included a second study, or a second published paper that we did as a follow-on from this study, just to give you an example of how the women undergoing AHR in Ireland, their experiences, what they're feeling about, what their priorities are, etc. So I'll move on. The background to the study was kind of in a roundabout way. We had a master's student called Lorraine Ronan, and I'm very much in the medtech regulatory space. And because of new medtech regulations, not to bore you too much, certain medical devices were going to have to undergo more stringent regulations, and some types of, I suppose, medical supplies, which may not have previously been categorized as devices, were now going to be brought under the medical device definition. And we wanted to look at, well, will this make IVF more expensive? Because there was products, just a very simple example, IVF media was being brought in under the definition of a medical device, and other items. And IVF is already a very expensive area. So that's how, I suppose, how we came at the study, to be honest with you. And I'll go through what we found now. So we wanted to review the Irish legislation and for AHR, and we wanted to review some other countries. So I think we looked at 12 other countries, some in Europe and America, New Zealand, Australia, etc. Assess the gap and assess best practice. So assess the gap in legislation with Ireland and assess the best practice as we thought in terms of, for the people undergoing the AHR. So basic facts, and just I think it's always important to, like, you know, put this in context that AHR is not regulated in Ireland, although it's practiced here since 1987. Now that's changing, and we'll go through that in the presentation. But at the time of the study in 2021, it wasn't actually regulated properly anyway. Ireland is one of the only European countries that didn't have any AHR specific regulation at the time. And that's bearing in mind we have 6,000 cycles on average of IVF treatment completed in Ireland each year. We now know from figures and basic research studies that 1 in 4 couples will experience infertility issues. And while they might not all need IVF, they might need some form of assisted reproduction treatment. And another little bit of context as well, just infertility is really the reason behind IVF, obviously, in AHR. And infertility is defined as the failure to achieve a clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. It affects 48.5 million couples worldwide. So, you know, and it's increasing. All the studies are showing it's increasing. And to Catherine's point, it's not only a medical condition, it's a social condition. There are social aspects to this. And, you know, people have been conditioned to believe that they might one day have a family. And, you know, there's huge social implications and psychological implications on family, you know, when people are suffering or having infertility. Now, at the time of the study, when we started the study in 2021, there had been a draft bill with the Irish government for 3 years, but it had not been introduced into law. Now, thankfully, that did come into law, or is in the process of coming into law in March this year. But we were literally in legal limbo, and I'll go through how we were in limbo and why that was a problem, I suppose, for, you know, for people undergoing the treatment, clinics, etc. The Irish Medical Council do provide some guidance in relation to AHR in their Guide to Professional Conduct and Ethics for GPs or registered medical practitioners, but it's not legally binding. It's a guidance, and, you know, they're about it's an ethical guidance, and, you know, professionals within the AHR space don't have to follow it, and not all AHR clinics would register as medical practitioners. So we were talking about a gap already when we started the study. Also, the clinics were not obliged to submit details of treatments conducted in their facilities or publish any statistics on their success rates, which again is another compliance gap. And there was no authority at the time dedicated to AHR. Now we will have an authority, and I'll get on to that. We did a number of interviews, and we did a questionnaire survey, and just to look at the types of treatments. The majority of people that we spoke to were undergoing IVF. That was nearly half of the study, 48%. And there's other types of, I suppose, AHR that they were going through, but IVF was the primary, I suppose, service or product that was being bought, because it is a product or a service. And the details of all that are available in the afterwards. I'll show you the bibliography. We asked people their reasons for undergoing a clinic, choosing a clinic, apologies, for AHR, and well, 64% said they did their own research on the internet. Now, that's very telling in terms of, you know, I know we all do research when we're buying something, but it's very telling that the majority of these people did the research on their own. Only 9% got GP's advice. Again, there's a very low percentage of recommendations from a friend, and that's probably got to do with it being a bit, maybe still a bit of a sore topic or a taboo topic. People might want to share that they're going through this. So that was an interesting finding. The factors affecting the clinic selection by the Irish women we spoke to undergoing AHR, cost was basically the primary factor. They selected their clinic based on cost. They reviewed the websites and tried to weigh up where will we go. The type of treatment they were going for was their second factor in selecting a clinic. After that, then it was knowledge of the treatments undergone. They might have some knowledge or awareness or know somebody that underwent those treatments, and they were kind of, you know, they were kind of based, but it wasn't a high priority for them. It was a low factor. In fact, you know, they were more concerned with cost and types of treatment. and awareness of regulations. And quite simply, as many of the interviewees said to us, we just wanted a baby at the end of the day. We don't care, you know, whether it's regulated or not. And, you know, you have to respect that, but there was a gap in the regulations as well. And which is why we did the study. The average cost in terms of our survey and our interviews was just under 15,000 per couple. Now, again, that can vary. And I mean, there's so many factors that can come into it, how many IVF cycles, etc. But you're talking, you know, probably €250 for initial consultation and an average of 4,500 for an IVF treatment. And again, the high cost can be is a huge driving factor in deciding whether you continue the treatment or discontinue the treatment, you know, if you don't actually have a baby at the end of it. And also medical insurance companies in Ireland vary in their policies regarding assisted reproductive treatments. They sometimes cover consultation costs and maybe basic procedures, but the vast amount of funding is covered by the patient. Okay, so again, that's a lot of stress, and it's a psychological strain, especially on women in the workplace. Just again on the costs of AHR, the Irish Health Review Board has stated that the cost of a single IVF cycle in a clinic can vary from thousands of euro because you can have your travel, your drug expenditure, and indeed some people travel abroad. And also there's a lot of what we call add-on or adjunct treatments in these clinics, and they may not be advertised, or you may not be told about them up front. And again, some of these aren't regulated, they've no proven safety or effectiveness data. So very much up in the air with this, you know, as to whether you should use them, or you need them, or you want them. And, you know, you may get marketing information while you're in the clinic getting treatment that are trying to push these on you. So that was another concern. Again, these add-on treatments are offered to improve, you know, your chances of a successful outcome. They might even, for example, offer acupuncture or other treatments. So again, in the Assisted Human Reproduction Bill, which has been brought into force in March 2022 this year, they don't really look at that. So that's a little bit of a gap, and they haven't really talked about it or acted on it. So that's probably a room for improvement with this in the legislation in future years. On the contrary, the UK clinics have to provide open and honest information on any evidence that surrounds add-on treatment. Now, in terms of the thematic factors, in terms of the legislation, every country we looked at was different, and there was different reasons for their legislation. And with religion being a huge driving force in a lot of countries, particularly Italy was one of the most conservative countries for obvious reasons because of, you know, the home of Catholicism historically. And they were very slow. They were one of the slowest countries in Europe to come along in terms of their legislation. So some countries varied in their legal age limit for ART access. Others, you know, had legal limits on that you can have for third-party donations and preservation of fertility donors, etc. The supports, the public and government supports varied from different countries. Some countries aided you financially, others didn't. And some, you know, so a lot of this was available in a lot of countries on the public system, unlike in Ireland, which was based on the private system. There also were factors around rules around cloning and surrogacy in different countries. So every country varied, rules around who can access assisted reproduction based on their marital status and their sexuality. And there was also a lot of legalese on whether embryo research can be carried out or not. So not to bore you too much, but just to basically mention that within Ireland, we've done things a bit differently because of our social and religious beliefs, and we were probably very much lagging because of the act being in limbo, the bill being in limbo. No, we do have the European Society of Human Reproduction Task Force on Ethics and Law, and because we're a member of the EU, you know, I suppose we can leverage them, but we had no legislation specific to Ireland that service provider clinics could follow. And the Health Product Regulatory Authority in Ireland, the Irish HPRA, they play a role, I suppose, in the quality of tissues and the storage of tissues rather than the actual governance of the clinic. So they only would inspect how the tissues were being stored, not the actual how the clinics were being run. So in our study, we've, not to bore you with two, every country, I picked out the two that we felt were kind of best practice. The Netherlands were deemed to be a star performer by us as within the study, because they have a standard health insurance package which includes IVF. So everyone living or working in the Netherlands is entitled to that. And I mean, we don't have that in Ireland. So that's all very positive for people that are trying to undergo this treatment. The Dutch government do decide the amount of cover they'll provide, and it can change annually, but the cover is there. The only limitations they have are the woman must be under 42 years of age, and she must have failed to achieve a pregnancy for a number of years. Now, then we go to the UK, and again, they were our other star performer. They have had an authority called the Human Fertilisation Embryology Authority since 1991, and you need a licence from them in order to operate in the UK. They not only license, but they inspect clinics, and they do regular unannounced inspections and scheduled inspections. So there's governance there. And they even interview patients. And if you get, as a clinic, you get a negative report from them, you can get your license revoked. So that governance is very important, and it's very important for the patients as well. Though, as our participants in our study said, they didn't feel it was important at the time of treatment, because they just wanted, to get through the treatment and have it successful. And they weren't too worried about the clinics. Sorry. And just again, the only bad note in terms of the UK HFEA, they have no authority over the prices that clinics charge or how they market their adjunct treatments. But if you have concerns, you can address them to a regulator, which I suppose, again, there's a recourse there. And the UK Act states it's the responsibility of the clinic to ensure that they use suitable practices. And IVF is free in the UK for women who are under 40, but not for over 40s. And again, that's been a bit controversial, because that's led to women from the UK travelling abroad for access to cheaper AHR treatments. So back to Ireland. We have no visibility to provide insight or comparison into the different fertility clinics in Ireland at the moment. The clinics report their success rates in different ways. And as I said, they can offer add-on treatments without any proof of their effectiveness. And I just made a note here that this is something that has been very controversial in the US based on how different states regulate different clinics. And it's been a source of public concern. So it is something that, it would be best practice to regulate them properly. The Joint Commission on Health in 2019 in Ireland and analysed the new Irish proposed legislation, and they basically recommended some changes that would bring Ireland more in line with European country-specific practices, and these included removing age limits, removing the limitation on the number of embryos that can be implanted, and including more funding be available and counselling services. Aideen, am I running out of time? Yeah.
Just one more minute there, Olivia.
Okay, so I'll very quickly finish. The conclusion of the study, we found, looking at different countries, there was no legislation for AHR that could be described as perfect in any country, but we felt the UK with the Netherlands financial legislation section from a patient point of view was the best hybrid practice model for adoption in Ireland. And to have set price guidelines for treatments and a financial support system in place, and also linked treatment for IVF to private health insurance. Now, I'll move on very fastly. After a study was published, I think it was published early 2022, and it was only published a month, and the Irish government actually announced it would adopt its bill around AHR treatment, which again had been absolutely terribly in limbo, and it was terrible that it was just left sit there, to be honest. But that's basically going to alleviate the financial pressures on patients. How it will close the gap very quickly, we'll now have a new Assistant Human Production Regulatory Authority, AHRRA in Ireland, and they'll provide regulatory oversight of the Irish AHR, like the UK had. And this is going to be very important for, again, maintaining good practice and, you know, monitoring clinic performance. Surrogacy wasn't addressed in Ireland. The new bill will legislate for altruistic surrogacy, and it will allow you to go abroad to avail of surrogacy. And the Irish Times, I just copy this in, it's called it a double standard. They won't allow surrogacy here, but they'll allow you bring in a surrogate from abroad, or a baby that was born to a surrogate from abroad. But at least that's closed that gap in the legislation. Finally, AHR will now be funded publicly, or will be made available in the public hospitals as a result of this new legislation, and they're rolling out what they call regional infertility hubs as part of the AHR bill passed in March. So that's basically it. I have the two studies are open access. Anybody can access them once they have the web link, or you could Google the titles of them. So if you want to read further or contact me, I can send them on to you. Thank you for inviting me, and sorry if I went over.
Not at all. Thanks very much, Olivia. That was a really fascinating presentation there. To be honest, I had no idea just how prohibitive the cost in particular was. That was quite shocking to me anyway. So we will open up now to questions and answers for maybe about 10 minutes or so. So I think we have Kathy and Anna managing the questions and answers. Has there been any questions?
I'll make a start, and thank you both so much for your presentations today. Our first question is from Marianne, and it's in reference to Catherine Conlon's study. Marianne's wondering if it was asked whether the women the participants in your study had children already, wondering if it would be harder to access services or to self-administer if they had to care for kids.
Thanks, Kathy. Thanks, Marianne, for the question. Yeah, it was something that people discussed in the interviews, Marianne. Again, the requirement to have 2 consultations mean often childcare was required for both. Now, again, when the remote consultation method was brought in, it meant, you know, women talking about being able to actually do the consultation with their GP on phone or video call, while kids were, you know, around or in the, you know, they could be in the same room. I remember women talking about, you know, setting the child up with the usual kind of Peppa Pig or whatever. So there was a greater scope to do that within the home environment. In terms of administering the medication itself, one of the things that women noted was the extent to which GPs and doctors talked with them about the pattern of their everyday life and where was an appropriate time that they could actually take the medication. So for women with children, often it was after children had gone to bed, they would self-administer the medication and hope that, you know, they expect that really over the course of the night, you know, the first few hours would be when they would be most symptomatic, and then by the time, you know, over the course of the night, the symptoms would have alleviated completely. So really it was a matter of women, they may have had a partner or other people who helped them care for the children at the time, but they were really integrating the abortion process, I guess, into their life. But having to go out to the consultations meant, seeking childcare, and again having the 2 consultations where they were face to face made that more costly, more difficult, or you know, a greater impediment to care.
Thank you.
We have one more question for Catherine from Valeska. And the question is, did the report include recommendations for improving current services? And if so, what recommendations were made?
Thanks, Valeska. Yeah, so we do have a set of issues for consideration. One of the things that we were very mindful of is that the findings from the study had a lot of implications for multiple kind of different stakeholders in the course of the research. So we felt there was an importance for some of the issues that were highlighted in our study to be considered by, you know, partners in the care process, like doctors and care providers, so that they could, we were aware that we're not clinicians. So there were things that we had to be mindful of, you know, what we could make recommendations are around. But the things that would have been kind of big headlines that we were looking at, and that seemed to have no clinical indication. Certainly the 3-day wait was something that our data indicated that women were saying there was, it wasn't in any way something that supported their decision making or consistent with the ways in which they were making the decision. There also is no clinical underpinning for a 3-day wait, and therefore the requirement of it in law seems to have no quality component in relation to abortion care. So what women said in the study was that idea of that being an optional element, that keeping a 3 consultation model as optional was something that they would welcome, but being able to access the care in a first consultation seemed to be more consistent with what women wanted. The idea of not being able to access care, that if you present to someone who's not a provider and they don't refer you on to someone who is a provider, that is very much at odds with broader medical practice. Broader medical ethics would say if you are a healthcare provider not providing a particular component of care, you have a duty to refer somebody on, and that duty not being observed. So certainly there, we made a recommendation that, you know, the Medical Ethics Council needs to look at that, and the ways in which conscientious objection is working in the law needs to certainly be addressed and thought through. The piece we didn't get to talk about today was women accessing or seeking care under the fetal anomaly component. And that requirement, the criteria for eligibility there of the 28-day that the fetus will be certified as not being surviving beyond 28 days. That's in practice seems to be a very, very high bar, and women describe that during the process of that assessment of their eligibility for that qualifying under that section of the Act, women felt incredibly removed from that decision-making process. And it's being conducted by multidisciplinary teams, and they felt completely out of the room. And women themselves were saying that a diagnosis of a severe life-limiting condition, not just a fetal anomaly, but a severe life-limiting condition, was something that made the need for abortion as much for them. And we know from the statistics from Ireland that people are continuing to travel, certainly to England, to access abortions for fetal anomaly, in numbers similar to what they were before the law was changed. And women in our study who did not qualify under Irish law felt incredibly abandoned. They felt that repeal had reflected a compassion for people with fetal anomaly, and that was not translated into the Act that was implemented. And so that was a component of the Act that we felt really needed to be looked at in light of our data.
Thank you so much.
Thank you, Catherine. I actually have a question for both of the panelists, so maybe I'll go to Olivia first. How do you think, or do you think, if possible, that workplaces can support people, you know, accessing these reproductive healthcare services?
I suppose it's a difficult question, Aileen, but I suppose a lot of it is about how aware the workplace that people are undergoing, you know, IVF, for example. And if they are aware, you know, I think I think most workplaces nowadays have policies that if you go to them, you know, they will accommodate you. But again, I suppose a lot of women feel that they can't say that this is happening, and they don't want to say it's happening, and there's still a bit of a stigma. And, you know, people are private and they want to keep private. So it's a hard question to answer, but all I can say is that, as with any other time in their lives, you know, when there's you know, somebody sick, or they're caring for somebody, or coming up to maternity leave, I think employers should try to be as understanding as possible. Because it is only a temporary process, and it might only be that they need a day or two here and there, maybe even just to work from home, you know. But it's very hard one. I'll see what Catherine comes up with.
Great. Olivia. And then same to you, Catherine, as well.
Yeah, thanks, Aideen. I mean, one of the things that in the going through the Shannon recently, there was a proposal for a bill, or a bill moved for early pregnancy leave. And we saw in our study that there were various kind of situations where women seeking abortion care may have needed leave from work, you know, for the procedure itself, or because there were some complications after it, and certainly women in the who are undergoing assessment for eligibility under fetal anomaly and who are dealing with a fetal anomaly diagnosis. There certainly seemed to be, you know, the need for compassionate leave was there. And currently there is no provision for maternity leave prior to 24 weeks gestation. So those acts that are, you know, currently underway to look for early pregnancy leave, or, you know, the other proposal was a work-life balance bill, there certainly seem to be a need for consideration of, you know, situations in earlier pregnancy that may need to requirement for leave. The issue of disclosure of, you know, there certainly does seem to be a residue of kind of stigma or silence around talking about abortion experiences that would, you know, have carried over from the way in which abortion was treated in Irish society. I suppose it's something that was very much, you know, prohibited by constitution and had a lot of stigma attached to it. So openness around abortion in workplaces didn't seem to be something that was much a feature of our data, I think. So it's really, yeah, how normalization, I think a broader notion of, you know, normalization was something we talked about, that would facilitate people being able to, you know, seek the leave and care and compassion and accommodations that they might need.
Thank you. I have a question here, and it's in reference to Olivia's study. What concrete actions could be implemented in Ireland to facilitate access to assisted reproduction here? New legislation might be implemented soon, but cost would probably remain high. Olivia.
Now, with the new legislation, to be fair, it won't be perfect, but it access to people that want to undergo assisted reproduction on the public health scheme, in the public sector health scheme. So if it doesn't happen they are setting up fertility clinics if it as part of the public health system. If it doesn't happen immediately, as with anything in our Irish health system, in the public health system, they will probably, I can imagine that they'll probably allow patients go to private clinics, and there'll be some type of funding from the public system. And that's what they do nowadays for all procedures and all types of services. But there is, it's very much part of the legislation, and the Minister for Health has discussed it. And I think I even have a snippet of an article there in the presentation, where they are setting up these outreach and fertility clinics, and they will, you know, they will fund it. So we're in a better state than we were. We're going from a place where we were just I think we were very poor in terms of the rest of Europe. And we had no legislation at all. So that we're now going to, you know, I think, dare I say, possibly up there with best practice, but it won't be perfect. And there's still a lot of people that are unhappy with the legislation, but it's better than where we were at the start of this year.
Great.
Thank you.
Well, I think that's just about all the time we have today. So thanks everyone for a really enlightening discussion. And we especially want to thank our panelists, Catherine and Olivia. And thanks to the Women in Research Ireland Committee for our help with organising this event. Please keep an eye on our social media channels and our mailing list for details of our next event. Thank you everyone, and goodbye.
Thank you.